Bladder health as we age, libido concerns, issues of pelvic health in general have long been a focus of my career as an obstetrician and gynecologist, from preparing for pregnancy to post childbirth, and specifically in perimenopause and well beyond menopause. Issues that women struggle with beyond menopause when it comes to pelvic health include the hormonal shifts as well as changes to pelvic structure and function. Science has come a long way and still needs to come a lot longer, a lot farther in the realm of female pelvic health, but we're getting there, and specifically in bladder health and what we can do about it, what the latest science shows us about testosterone in women, for instance. And also, when you're struggling with bladder issues, urgency incontinence issues, or stress incontinence issues, dryness, etc., what who you need to see, what questions you need to ask, and how you navigate care is as important as that initial visit. Preparing for it becomes critical. So, today on my show, The Girlfriend Doctor, I'm inviting a colleague, Dr. Rena Malik. She is a specialist in sexual medicine and female pelvic medicine and reconstructive surgery as a urogynecologist, and is a menopause certified menopause practitioner. In her practice, Dr. Malik focuses on patient focused, individualized care in bladder health, sexual dysfunction, hormone management, and the compassionate management of non narcotic pelvic pain. She's located in Beverly Hills and Irvine, California, and her extraordinary contributions to the realm of urology have earned her the distinguished title of the 2023 American Urological Association Young Urologist of the Year, with a prolific portfolio boasting over 80 peer-reviewed publications. She continues to contribute to the advancement of innovation in the field of urology, especially in women's health. She is an online content editor for the Journal of Urology and Urology Practice Journals. Join me in welcoming, for this very important pelvic health discussion, my colleague, Dr. Rena Malik. Well, welcome, Dr. Rena Malik, to the Girlfriend Doctor Show. It's great to have you here.
Great to be here.
I've been so interested in your journey, and also I've loved watching you. For our audience, she is a really prolific writer and influencer. Her YouTube channel is just amazing and so candid. So one of the things I've respected about you and your teaching is your candor. And what is your journey? What's your inspiration behind your career?
Yeah, so it's sort of you always have that one moment that you remember that sticks with you. And so for me, it was a patient who we did a surgery on for bladder cancer when I was a resident, and she decided to have a specific type of diversion, which was where she would now have to catheterize through a little stoma on her belly to empty her bladder. And instead of using her normal bladder, which we had to take out for cancer. And so when we did that surgery, the surgery went great. She did fine. She went home, no issues. And that's uncommon because bladder cancer surgery is very complex. There's often complications. But lo and behold, within that first month, she came back 3 times, got admitted to the ICU, had so many issues, near death experiences. And we found out that basically the reason she was having so much trouble was because she wasn't catheterizing herself. She didn't realize that she had to actually change the way she emptied her bladder. And for me, that was the moment where I was like, you know what? We can do the perfect surgery. We can do everything right. But if we don't educate the patient on what's going to happen or what they can expect or why things are happening, they're not happy and potentially we're harming them. And so that was the moment where I realized, like, for me, health literacy and educating people was so important. And it sort of just went from there.
Yeah, no, I think that's so critical again, and listening to your patients, right? It's always that letting them know that they're heard, I think is such an important therapeutic part of our encounters. Now, you have your practice in Beverly Hill and Irvine. And what are the most common situations that you see in males and females?
Yeah, so for men, it's a lot of issues with erections, low testosterone with symptoms, as well as issues with ejaculation. For women, it's a lot of low sexual desire or loss of interest in sex, changes in orgasm, changes due to menopause, obviously, that affect our genitourinary genitourinary tract, but also the entire body, right? And so I see a lot of that. And then I work at the Veterans Affairs Hospital. I see tons of urinary incontinence, overactive bladder, enlarged prostate, a lot of sort of things that affect people that people think are no big deal, but these people are really suffering. I mean, the amount of stress they have from dealing with these issues, the cost of dealing with, products to help with leakage, it does really add up and has really huge impacts on the quality of life. And so my career has been entirely focused on improving people's quality of life. I don't do cancer surgeries anymore. I pretty much deal with the outcomes of patients who are either struggling with quality of life, or if they've had a cancer surgery and they're dealing with issues after that surgery, how can we optimize their quality of life?
I love that. And then when you look at that optimization of their quality of life, what are some um, key aspects that you put into play?
Yeah, I think that optimization is not sexy. People love like hearing about biohacking and all this sort of stuff, but at the end of the day, you need four major pillars of health, right? You need diet, you need exercise, you need sleep, and you need stress reduction. None of those are easy. None of those are things that people come naturally to people. And so in today's day and age, we have to work on those four pillars before we can start thinking about the biohacking and the supplements and the God knows what else, right? We need to fix those four things because those are so integral for our overall health. So, for example, for your sexual health, in order to have normal functioning genitals, you need good blood flow, you need good hormone health, you need good nervous function, and all of that is founded in good overall health. And in fact, sexual health is a biomarker of your overall health. So, if things are not going well sexually, that could be a sign that there's problems elsewhere in your body, particularly in your heart. And so, it's something to take seriously.
I agree. And I love how you say sexual health is health. Right? It is
Mhm.
health. And you said, okay, it's not something that we're going to giggle about in the back room. This is real health and shamelessly, guiltlessly, let's talk about it. So let's dive in. When we're talking about sexual health, especially in women beyond menopause or perimenopause and beyond, and dealing with issues like dryness, pelvic floor dysfunction, incontinence issues, what are some of the most common things that you see?
Yeah, so pelvic floor issues, they span the gamut. So we know that 1 in 3 women after pregnancy will have urinary incontinence through their lifetime. And so that's very, very common. Think about you and three of your best friends. Someone is struggling with some degree of urinary leakage. So that's very, very common. That's usually due to a weakened pelvic floor. But sometimes we see issues with a tight pelvic floor, and that's one that's not talked about often enough. That's because, we live in a very stressful society. Almost everyone's dealt with some sort of trauma in their lifetime. They have high stress, high anxiety, high pressure lifestyle. And those patients, just like people get TMJ where they clench their jaw, they can also get a tight pelvic floor. And they don't really know they're doing it. They're just clenching down there. And it's causing a whole host of symptoms that can include things like difficulty urinating, difficulty having bowel movements, pain with sex, pain with orgasm, maybe even in men erectile dysfunction, and back pain, hip pain. It's all interconnected, and so I think really the pelvic floor is such an important part of our structural being that we just don't pay enough attention to.
I couldn't agree more. That is like the focus of my work. So I am very interested in this. And also it reminds me, speaking of urologist, Dr. Neil Galloway at Emory, who I trained under in the urology department, he would say, okay, you want to evaluate a woman's, pelvic health or, pelvic health in general, women or men, have them spread their toes, right? Have them spread their toes because their sacral nerves, S2, 3, and 4, innervating the pudendal nerve, the pelvic nerve of our pelvic function, bladder health, sensual pleasure, orgasm, et cetera, the same nerves that innervate our feet. And so looking at that connection between, like you said, the nervous system and issues related to that when it comes to a loss in sexual function or bladder control, et cetera, is important. Okay, where is it coming from? Is it muscular? Is it neuromuscular? And it's usually, is it hormonal? It's a combination of everything.
Absolutely. And you know that some of the treatments we have for bladder function are neuromodulation. So we actually, use devices or surgeries to affect the nerve roots to help our nervous system function better.
Yeah. Yeah, absolutely. And when it comes to the bladder health in general, you talk about bladder health myths. So, what are some prevalent myths about bladder health that you'd like to debunk?
I mean, there's so many, but one is I would say is more water is always better, right? So people, we live in this like hyper hydrated society. Everyone's walking around with their Stanley cup. I mean, for now it's Stanley cups. Who knows? 10 years from now, it'll be something different. But, it's great to be hydrated. I think people feel better. They need to be hydrated. That's not a problem. But when you're starting to have bladder problems, a lot of the times it's because people are just drinking a lot of fluid. When you drink a lot of fluid, you're going to urinate more often. And so what I tell people is look at the color of your urine. Your body does a good job of telling you how hydrated you are. If it's clear, you can probably cut back on how much you drink. If it's dark yellow, you're not drinking enough. And even when it's dark yellow and concentrated, that can irritate the bladder too. So you want to always be aiming for like a lemonade light yellow color. And that really tells you that you're drinking enough and you're reaching your goals, which should be to stay well hydrated.
And so, when it comes to like pelvic, incontinence, what's the latest treatments for incontinence?
Well, I will add that one of the other myths is that incontinence is normal or leakage is normal. Like everyone just leaks after they have babies. That's a normal thing, and it's not,
Or
right?
in
It's not a normal
menopause?
thing.
Yeah.
Yeah. And same thing with UTIs. They're not normal. Getting UTIs over and over again is not normal. These are things we see very often in women, and particularly as they go through the menopausal transition. So in for terms of treatments, I mean, it depends on what kind of leakage you have, right? So there's leakage that happens when you gotta go, can't make it. And that is called urgency incontinence. And that's due to a dysfunction in the bladder, right? The bladder is contracting before you're ready for it to. The other type of leakage, which very commonly women will experience, like when they're jumping on a trampoline or they're lifting weights or they have a really hard cough or a hard laugh, that is called stress incontinence. And that's because the pelvic floor muscles, which hold, sort of support the urethra and bladder, are weak, meaning that now because you don't have that hammock of that tension underneath your urethra to help keep urine in, it's now leaking out when the pressure in the belly is higher than the pressure in the urethra or the P tube. And so they're caused by different things. And so the treatments are different. And traditionally, for overactive bladder or urgency incontinence, we talk about medications, lifestyle changes, like we talked about, sort of hydrating appropriately, avoiding things that can irritate the bladder, avoiding constipation, weight loss. Those things can all, and quitting smoking for everything is good. But those are sort of traditional treatments, and we have medications. There are newer medications coming out for overactive bladder, which have less side effects, which I'm pretty excited about because the older ones had pretty rough side effects, constipation, dry mouth, dry eyes.
Dry
And then there's,
vagina, right?
yeah, dry, everything dry, right? And then there now, in terms of overactive bladder, we have surgical treatments like Botox injections in the bladder.
Mm.
We have this sacral neuromodulation, which has been around for a long time, as well as PTNS. These are ways that we use to sort of use our nerves and sort of optimize nerve function to the bladder to help prevent those contractions.
When
But
when you s
now,
when you
down,
talk about
yeah, go
the
ahead.
neuromodulation, what are you referring to?
So there's two neuromodulation treatments that we have that have been around for a long period of time. One is called sacral neuromodulation. That's like a bladder pacemaker where it's implanted in the backside. That essentially is a lead that stimulates the nerve root that you talked about that goes to the bladder. And so that's an implanted device. It has a small battery that's implanted. Usually you have a staged approach to make sure it's going to work or not. And then there's PTNS, which is like basically like acupuncture. We put a little acupuncture needle into the ankle that stimulates the nerve, the posterior tibial nerve, which goes up to that same nerve root and sort of stimulates, again, normalizes nerve function. So those have been around for quite some time. But interestingly, in the space, there's now newer ways to do this, right? Because these other ways are either surgical or you come in for this acupuncture treatment once a week for 12 weeks and once a month, like forever, if it's working. And so that's really challenging for people to keep up with, right? So now there are newer options. There are implantable PTNS devices in the ankle. So they're like minimally invasive procedures done in the office. There are options where you can get the lead implanted and wear like an underwear instead of having a battery so you have less of a scar to stimulate. There's lots of different sort of interesting devices coming out in that area. So I think, I'm excited about there being more options. There's also injectable gene therapy, Euro 902 for the bladder. So lots of different options there. In terms of stress incontinence, before I go there, anything else you want to follow up with that for the
Yeah, no, I
overactive
mean, I
bladder?
think there's so much. There's so much
Right.
that we can do and that we can avoid some of those, the anticholinergic drugs that we were using for bladder incontinence, which has now been or with urge incontinence, which has now been associated with increased risk of dementia and, cognitive decline. So we really want to avoid
Yeah.
those pretty much as much as possible.
Yes, and I honestly, the insurance companies need to, get with the program. That's the problem. Is really the insurance companies are still not covering the newer medications, which are called beta agonists. They're not covering those medications because they want you to try the anticholinergics first. And we know, especially in the aging population, these medications have serious
Yeah,
consequences. And when you're on them for more than 3 years, there's a pretty strong link with dementia. Now, it's a correlation, not a causation, but it does certainly give me pause. I'm sure it gives you pause, and many people who prescribe these medications pause. So yeah, but I'm excited. There's so many options, and this is like a huge problem. Like 16% of the U.S. has overactive bladder. That's a lot of people, almost one in five. So and then stress incontinence, that weakness. So, the first and foremost is typically going to pelvic floor physical therapy, which is doing Kegel exercises or pelvic floor strengthening exercises. Now, these are great exercises when you know how to use them. So, I find that oftentimes people try to do them at home. They might actually not be doing them correctly. They might be straining or squeezing their butt or their belly. And so that's why I think having a pelvic floor physical therapist nowadays, there's even like online programs where you can access a pelvic floor physical therapist, which I think is great. I mean, ideally,
right.
there's no comparison to having someone in person,
Mhm.
but I'm sure your listeners are from all over the world, and not all of them will have access to that. And so that's great. And they teach you how to do those exercises and then use them when you're functionally like about to cough, about to sneeze, about to load, a weight or some, so that you can sort of prevent that leakage. Um, there's also like pessaries and devices that you can buy that will sort of put pressure on the urethra so that it prevents that leakage. Pessaries are just a silicone shaped dish that goes in the vagina that can help sort of provide pressure. You can also get like sort of like tampons or like wider, thicker tampons that go in that also provide pressure that you can buy over the counter. So those things can help. And there's actually a newer company that just came out with a pessary that's deployed sort of like a tampon. So I saw that at one of the meetings. That was sort of cool. So there are some things going on in that space. And then there's traditionally been slings, which is the most sort of it's using a mesh product underneath the urethra to support the urethra. But now there's also always been bulking agents, which are essentially little, they've been different sort of materials, collagen in the past, and calcium based products. Now there's water based gels, polyacrylamide gels that are inserted into the urethral wall to provide some resistance. And these are really nice. The outcomes are much better than the older injectable agents, and they are just an outpatient procedure. So I think for a lot of women who are busy, don't want to take the time off to do a surgery like a sling, these are really nice options to try, and they don't really tend to require downtime and have very low risks. And so ultimately, I think that's really exciting too.
Yeah, I love that, and even PRP combined with, like, hyaluronan or some of these polymers, you can do or just PRP into the urethral wall, and that can have some benefits too.
Potentially. I mean, there's not a lot of robust data on PRP for this purpose. There's also some data on muscle stem cells for urethral, uh, sort of not bulking, but injecting. And the initial trials were not great. So I think there still needs to be some more investigation to say, like, yes, this is prime time. But, who knows? I love this idea of regenerative medicine. I think we're on the brink of it now. And as we do more studies, we'll know more.
And what about hormones for the pelvic floor and stress incontinence? How do you
Yeah. So
implement that?
hormones are just, I think everyone should be on vaginal estrogen. I feel like I joke for men, tadalafil should be in the water, and for women, vaginal estrogen should be in the water. Like it's essentially what happens as you go through menopause is your estrogen goes away, right? But it really drops precipitously, particularly in the genitourinary area. And those tissues have so many estrogen and testosterone receptors. And so when those hormone levels go down, what happens is the labia shrink and resorb, so those inner lips basically like shrink and go away. The clitoral hood gets a little bit thinner. The tissues itself get thinner, the vaginal tissue. So everything is sort of shrinking, getting thinner, more friable, more uncomfortable. And those receptors are also on the bladder. So there's estrogen receptors on the trigote of the bladder. And so when you get rid of some of those receptors, or they're not getting activated, then you're starting to see more overactive bladder. So I think all women with overactive bladder should be on vaginal estrogen. Anyone who's having any bothersome changes or dryness should be on vaginal estrogen, as long as there's no contraindication. And the contraindication is active breast cancer, which is a small subset of the population. Almost anyone can get vaginal estrogen. So I think it's definitely been shown to be beneficial for overactive bladder. In terms of stress incontinence, not as robust in the data, but it makes sense. There's also estrogen receptors on the pelvic floor muscles. So giving estrogen around those areas is going to help overall. And so I think that, there is definitely a role for hormones, particularly when you're peri and postmenopausal, because unlike hot flashes, which tend to go away, these changes don't go away and in fact can get worse as you age.
And I think it's so important to recognize this because, these are hormone sensitive tissues, especially around the vulvar vestibule, right? And that's
Mhm.
linking to the bladder and bladder sensitivity or overactive bladder. So topical hormones, and I'm big on DHEA topically, clitoris to anus, because we don't want anything there to
Mhm.
atrophy, nothing. We want to keep it
Yes.
healthy and functioning, good blood flow, good nerve flow. And, I followed the work of Dr. Ferdinand Labrie out of McGill University in Canada since the early 2000s. And so, looking at that, DHEA will go to all three layers of the vaginal wall where estrogen is at the mucosal layer. I think it has other effect. I mean, it definitely has other effects too. It's a sensitizing agent. It's beautiful. But with DHEA, you're also getting that like return of the rugation and the
Mhm.
glandular production, and that can be beneficial. Plus, it's really good for the clitoral hood and the clitoris in general. And talking about the clitoris, let's talk about sexual function and restoring sexual function and orgasm.
Yeah. So what tends to happen is as you age, you can obviously everyone, men and women, experience some changes in nerve function. So their nerve receptors become a little less sensitive. So they might notice that they need more stimulation to get to the same level of climax. In women, as you mentioned, you may also see clitoral changes. You might see atrophy or thinning of the actual clitoris itself, as well as the hood around it, which can make it sometimes more sensitive, or conversely, make it more difficult to optimize hormones. The other, to optimize the ability to orgasm. The other thing is that hood, we're not taught to ever pull it back, but some women develop adhesions, right? Like just like
Yeah.
little boys get smegma under their foreskin, that happens to women too. You just don't know it because the clitoral hood is our foreskin. It gets stuck oftentimes onto the clitoris. And so that becomes a problem because those things can be irritating. They can mute your orgasms. And so, like, look at your clitoris. I would encourage everyone listening, take a mirror and look down in the vulva and look at your clitoris. Pull back that hood, make sure it pulls back. You should see a beautiful gland, a beautiful round bud, a gland of the clitoris completely. And if you're not, that means you might be getting a little bit of adhesion there. And so, and I tell women when you're taking a warm bath, just gently pull it back. You can apply some estradiol cream if you have it to that area, DHEA, whatever your preference is. But that can help sort of make the tissues more pliable and allow them to pull back a little bit and clean that area.
Yeah, I'm so glad you talk about that because that is critically important. That's the thing. We have a mirror in the GYN room, right? So you want to look
Hmm.
and see and understand your anatomy. And so that way you can easily detect when, okay, something looks off, something
Yeah.
looks strange here, and or it doesn't feel good. And when a client, the one of the areas to address is when a woman is struggling with this issue, it can be very difficult to talk about bladder health, pelvic health, sexual health with their doctors. How do you open the door for this
Yeah. So,
conversation?
one I would say is as women, we tend to take care of everybody else. Like we can advocate for our kids, our husband, our parents, whatever your partner doesn't have to be a husband, but we advocate for everybody. But when it comes to ourselves, We don't. And so I would tell everyone listening is like, you're worth it. Like, actually, you are the most important person. And if you can't take care of yourself, you can't take care of all those other people. And so it's really important to be open with your doctor. But for me personally, I try to, I mean, obviously people seeing me know they're coming to see a doctor about their issues, but I also have a very extensive questionnaire beforehand so they can actually like write in things. We ask about masturbation, we ask about orgasm, we ask about desire, we ask about all these questions. So people are like, oh, she cares about this stuff. Like she
Mhm.
wants to know this stuff. And so that's one. Two is I just ask them and I just let them talk. I say, what does sex look like for you? Or what does intimacy look like for you? Or how is it affecting your life? And try to really get a sense of like, not just the problem, which is what a lot of doctors do. Like, okay, you leak, how often, how many pads, whatever. But it's more than like, what does this mean for your life? Like, what's going on with you? Like, how do you feel like you're limiting things you used to enjoy? So I can really get a sense of like what the big picture is. And the really important thing, as you mentioned earlier, is listening. Like, what is your goal? Because your goal may be very different from my goal. And so I want to know what you want. How realistic is it that we can get you there? So I can give you a sense and how long it might take. Like, we might need to do two or three things before we get you to the place you need to be. But as long as we're together in the journey, that's what matters.
Yeah, no, I agree. And just being open to ask the question, to be a safe space to hear the answer, that's important.
Yeah.
And then just for everyone listening, advocating for yourself. There are doctors like Dr. Malik who is listening and is able to address these issues and give you real help. So if you're hitting a brick wall, so to speak, keep looking. Keep looking, keep asking, keep talking about this. And then the other aspect too, when it comes to sexual health and libido, is testosterone. It's not just a male hormone. And I love when you talk about this, especially for women.
Yeah. So testosterone is we have 4 times more testosterone in our bodies than estrogen, and it is such an important hormone, right? When I talk about it for men, I mean, I sort of talk about it to women the same way I talk about it to men, and that's where I think like there's a disconnect, right? We've never been taught about testosterone for women, but testosterone there's receptors in your brain, so it helps with clarity, cognition, mood. There's
Sleep.
receptors on sleep. There's receptors on your muscles, right? So it helps with muscle growth. It helps with bone density, just like estrogen, because there's some conversion there. Um, it helps with desire. Now that's a huge one, right? Desire for sex, desire to that urge you get when you want to have sex. It helps with that. It helps with, to some degree, just genital function, right? So in men, we talk about how it helps nocturnal erections or nighttime erections. Women also get clitoral tumescence all through the night, and that's normal and healthy, right? We're getting good blood flow to the clitoris. It's helping it function well, get good healthy blood flow even when we're not sexually active. And so when that goes away, that's a problem, right? Because that's when you start seeing atrophy or changes, and then your orgasms become more difficult because the tissues are not as robust and it's harder to feel aroused. And so really important for all those things. And as you mentioned earlier, testosterone topically is very important for the vestibule, that area in the vagina between basically the labia minora and the vagina itself. There's this special area of tissue which is embryologically different from the vagina. It has so densely innervated with estrogen and testosterone receptors, and so it's so important. And like you, I think that if there was more robust studies on this, we would see how much better estrogen and testosterone, or DHEA, essentially is than just estrogen alone in these tissues. And so I think there's just so many benefits to it, and it's not scary, right? Like, people are like, why would I take testosterone? It is not scary. It is actually given in physiologic doses when you're prescribed it. If the one sort of on-label indication is hypoactive sexual desire disorder, which is low libido in postmenopausal women. But there's really very little data in terms of like measuring testosterone levels, what's normal, what's not normal. The studies, some of them use different types of assays, which are really poorly appropriate at low values. And so this is garbage, right? Garbage in, garbage out. And so really, what's normal? So for me, what I say is it's about 1/10 of a man. So a man's low, according to, many societies, tons more data on men, 300 nanograms per deciliter. So for women, I say 30 nanograms per deciliter is sort of a cutoff. And so we want to keep women in a physiologic range between 30 and 100 or so. And So when you're low and you're having symptoms of low sexual desire, using testosterone at 1/10 the dose a man gets, either through a topical, either cream through a compounding pharmacy, using the male gel, using 1/10 of it, using an injectable from a compounding pharmacy, or if you're lucky to be in a country where they have patches, like I think Australia or New Zealand has a estrogen patch, I mean a testosterone patch, then you can get those things. But ultimately, there is several benefits. Now, the biggest benefit has been described in low libido, ultimately. But I suspect that with more data, we will find that there's going to be benefits in all the areas I mentioned.
Yeah, I definitely think with bladder function, I mean, I know with bladder functions, as a young gynecologist doing sling procedures, I had a conversation with someone at a conference, a hormone conference, and he was telling me that this is how I learned about this in 2000, but that using vaginal testosterone suppositories to help with incontinence symptoms and to help with orgasm. So I was using it in my patients preoperatively before I would do a sling procedure, because at that time in the 2000s there were, all these lawsuits for mesh erosion, et cetera, and I wanted good tissue, especially in the postmenopausal woman, to operate on. And so I started using the testosterone suppository preoperatively and up to 2 months ahead of time. By the time they came in for their visit, they're like, my stress incontinence is gone. Wait, I ran 5 miles without a pad. I'm having the best orgasms. I'm like, okay. So, number one, can't do your surgery. You're no longer symptomatic. But it was so eye opening to me. And from there, just really working and tweaking the formulas and customizing them, working with compounding pharmacies to optimize hormonal application for women. And again, being able to use testosterone on the clitoris, that's game changing for that uh, main primary source of clitoral orgasm, too. And so you can rejuvenate that even well beyond postmenopause. So I love that you bring this up and you really normalize the conversation about testosterone for women, that it is more abundant in women than our estrogen levels. And, it does affect the muscle cells as well, muscular cells and those receptors for that regeneration. It's game changing. And
Absolutely.
not to be afraid of it, especially when we're using physiologic doses. And
Yes.
that's where I think, in this gamut, have been in this space for a long time, seeing really high dose testosterone for women really kind of knock out some of the HPA axis to go to, okay, that's not good. We need to go physiologic. And I would say start low, go slow, but you want to get optimum very quickly. And I think there's
Yeah.
so much to that when you know where testosterone's going.
And
And
I think the other thing about what the numbers are, people get very fixated on the numbers, but at the end of the day, like, how do you feel, right?
exactly.
Are you feeling well? Are your symptoms well controlled? Are you having any side effects? That's what matters more, because there are no currently commercially available tests that will actually look at the androgen receptor, look at the number of CAG repeats on the end, which tells you how sensitive it is to the presence of testosterone, right? We don't have that yet. And so I can't tell you individually how much you need, right? But I can talk to you and look at your symptoms and decide what the right amount is.
And look at your anatomy and look to see that it's actually responding, right? I think that's an
Right.
important piece too, as the individual using testosterone, being able to look, am I seeing positive changes? Am I feeling positive changes? And I always say, test, don't guess, but treat the patient, not the labs. And
Yeah,
it's a
absolutely.
good rule of thumb. And other thing that you address in your work is the effects of stress on the bladder. I would love for you to speak to that because, and stress is everywhere, and I'm big on increasing oxytocin, oxyplay versus stress management conversation. I think it's two sides of the same coin, but the effects that stress can have on the bladder and what we need to know about reversing those effects.
Yeah, so it goes back to that pelvic floor, right? So when you're stressed, right, your pelvic floor tenses up, just like your shoulders tense up, your neck tenses up, whatever, everything else. And so your body is saying, hey, I'm stressed. And now your bladder sits right on top of those pelvic floor muscles. So when you're stressed, you may notice, hey, I'm going to the bathroom a bit more than I was the other day, or gotta go really bad. Like I can't hold it. Or I'm waking up more often because you're still dreaming about your stress. Like you clench your jaw at night, the same thing. Your stress is still taking hold. So So it's still waking you up because you're like, oh, I got to pee. And you go pee and you're like, ah, not much is coming out. Or maybe it hurts when I pee. Or maybe, um, I'm struggling to empty. I'm trying to push or strain. Now, these things need to be evaluated, right? You could have a real physiologic issue that needs to be addressed, but it can also be just stress that's causing your pelvic floor to tense up, which is then causing these symptoms. So, what do you do, right? So, it's how do you learn to relax these muscles? And interestingly, the same things that you would do, some of the things that you would do are some of the things that you would do to relax anyway. So, like diaphragmatic breathing. So, you're actually taking these big diaphragmatic breaths. They're causing relaxation of the pelvic floor muscles, but they're also calming your whole nervous system down, right? So, they're doing those sorts of things. You can also do exercises like happy baby pose, child's pose, figure four stretches, like deep low squats. Doing all those sorts of really good, nice stretches are going to help relax that pelvic floor. And, ultimately, it's like, okay, what I think the sign that people should say is, okay, if my body is now responding to stress, that's a signal to me that I have to do something else, right? Increase play, increase fun, great. But you also have to look at like your life and be like, what can I drop? What can I get rid of that's causing me stress? Or how can I modify things? How can I even think about the way I'm talking to myself or the way I respond to things in my life? And getting someone to help with those things, both for the physical aspect of seeing a pelvic floor physical therapist, a urologist, a gynecologist, and also like maybe a therapist to help with the stressors, and potentially a sex therapist if it's related to sex that you're seeing more symptoms. So I think just realizing like, hey, this is a sign I need to get evaluated, and something is wrong. I think this is the thing is you go to your doctor and say, I know something is wrong, but they do all the basic tests. There's no infection. They may even look in your bladder with a camera. There's nothing there. And they're like they do a basic exam. They say, oh yeah, nothing major. And you go home and like, no, something's really wrong. Yes, something is really wrong. And that doctor was focused very much on the physical manifestation of a problem, but there's so many parts that work together.
Yeah, no, I think that's such an important discussion because, say 90% of all doctors' visits are because of stress-related complaints. And so if we can just handle that, play more, have more fun, let go of things that no longer serve us, and really nourish the cathedral of our spirit. Our body is the cathedral of our spirit. How are we taking care of it? And that relaxing the pelvic floor is a big issue, especially if you've dealt with incontinence issues. You're more likely to clench and contract. And that switches me to another sexual topic is clenching when you're or trying to have an orgasm. And I was listening to your video on this, mostly targeted towards males and their clenching, but it's the same is true with females and clenching during that orgasm. I had a conversation with a friend of mine not too long ago at a party, and she's like, "I don't know how to have an orgasm without clenching and holding my breath." So, what do you say to that, Rena?
Yes. So this is the problem, right? An orgasm is supposed to be a release. It's essentially that's what's happening in your body. And what happens is first of all, you're really like building up, obviously you're building up arousal, like you're feeling good. And a lot of times you want it to extend. You want to like continue it for as long as possible. And so you clench down and you probably, I'm sure many of your listeners have been there. You get to climax and you try to hold off, but it comes anyways. But then it's not as powerful as it would have been if you had just relaxed into it, right? And so that's what happens. If you clench up, and tense up those pelvic floors, they can't get a full release. And so there's something about like relaxing into pleasure, like breathing, enjoying, like being luxurious. I mean, that's part of also how society views sex. It's like this rush thing, like get it done. We got things to do, or like, again, once you're in a long-term relationship, it's like, oh, is it sex again today? Like, I don't know. It becomes less exciting. And so it's sort of like, how do we find that play in sex again so that we can relax into it? We can luxuriate with it. We can have fun with it. And you can use those hacks, like try to breathe, relax, like try to just relax your body, take deep breaths, like enjoy it and think about it, like when people are getting really up to climax, they're panting a little more. They're revving up that sympathetic nervous system, which is what sort of activates when you have that climax. And so You want to sort of relax, breathe into it. And you know what? Sex takes practice. So does orgasming to get the most like robust orgasm possible. And you'll realize like sometimes you will have a better orgasm because you've had more foreplay, you've had more fun, you've had more time to get aroused, whether it's with yourself or someone else, right? And so it's the same thing if you're rushing sex, if you're clenching down to try to edge or try to hold on, but you're just like that can actually create a dysfunction, right? Because we want to relax. And so it's sort of a matter of like practicing, figuring out where is that time. If you want to edge, great. But like you don't want to get to that point where you're like just teetering and then you orgasm anyways, and then you've clenched out and now you've created a little bit of dysfunction. You want to get before you hit that point. So that takes a little figuring out your body's cues, understanding when that's going to happen, and sort of just, trying to relax into it.
And play with it a little more. Breathe into
Yeah,
it because,
absolutely.
like you're saying, clenching is gonna constrict the blood flow, and so
Mhm.
that can diminish the end result sometimes. But play
Yeah.
different ways. I always say there's sports sex and there's energetic sex and everything in between.
And there's a place for every kind of sex,
Yeah.
but you should allow yourself to enjoy it.
Yeah, yeah,
The whole
absolutely.
process, not just the orgasm. I think it's not just about the destination, enjoy the journey.
Well, and a question for you, very often couples have been married 15 or so years and like, well, it's just not as exciting anymore. We're just, run out of ideas. What do you say to that couple? Or they become
Well,
roommates instead of lovers?
Well, you know what it is? It becomes one like it's good to have a routine. It's good to have something you enjoy, you like that always works, right? It's like your favorite meal. You might like a bowl of pasta with red sauce, right? Some meal that's your go to. It always feels good. You always feel satiated afterwards, but you couldn't eat it every day. Right. And so the same thing with sex. You can't have the same type of sex every day. And what I say to people who say they can't think of anything else, it doesn't have to be crazy. It can be as simple as doing it in a different room, on a different side of the bed, like turn your head the other way, use instead of holding yourself on two arms, hold yourself on one arm. Like it can be so small, but it just has to be something slightly different, right? And then I would say, like, I would argue, certain that you've not talked about all your fantasies or things that you might like to try. And that's one really sexy way to connect. And also, like a great way to just say, hey, maybe this is something we'd like to try, and maybe this is not, but being open to just talking about it and seeing like where would you be open to trying something that might be a little bit different.
I love that suggestion. I mean, I think that's just that novelty. And I've met a couple, they were in their they were 72 and they'd been together for over 20 years. And they say, we make sex on a date night. We have a date night for sex. And that's part of
Hmm.
our routine. And the biggest thing is we challenge each other with a new idea. And I loved that. I'm like, okay, after 20 years together, keeping everything together and fresh and active, especially, as we age and that longevity, that's the oxytocin in a relationship, right? We get a lot of oxytocin when we are intimate and especially when we orgasm or have climax. So that's that bonding cement that helps with relationship longevity too. And say the health span should equal our lifespan, should equal our sex span.
Absolutely. And I would argue that scheduling intimacy is probably one of the underrated tools that people use. Like, we schedule date night to go have dinner and talk. Like, we should schedule time for intimacy. We schedule time to go have brunch with our friends or go to the fitness class that we want to go to or whatever. So, schedule time for intimacy because it just gives you something to look forward to. Like, when you were dating, right? You would like think about your partner and you would be like, oh, I'm going to get dressed for my date and I'm going to get excited. I'm going to smell good. I'm going to feel good. Sex might be on the table. Same thing. Schedule time to be intimate together because I think it's so easy to just like, oh, I'm not in the mood. Let's let it go. But like a lot of times, as you know, like we have what's called responsive desire. You actually need to be intimate or be close before you start being, oh, yeah, I like that. I want that desire. I want that. I have that urge again. It doesn't just come out of the blue anymore. And that's okay. That's completely normal.
Yeah, I love that. I love that because, the concept of, well, we need spontaneity. Now you need, there's that planning, that space, that warm up. Foreplay starts in the morning with that cup of coffee. I don't know. But like and if you know that's coming, then that helps you prepare, warm up, open to it. And it's not all of a sudden I'm laying in bed, I'm falling asleep, and it's time for sex. Wait, I'm too exhausted. And so
Right.
I do agree, and that's a it's a beautiful thing, and I think that's also has creates more open communication in a relationship too. There's so much. I mean, I could keep talking with you and go, into more topics on, more areas in this discussion, sexual health, bladder health, pelvic health. I mean, it's really critically important. So how does our audience connect with you? Share first tell us how our audience can connect with you. Then I want to ask you a couple questions more.
Sure. So you can find me on podcasts if you're listening, Rena Malik MD podcast. I'm on the YouTube, Instagram, Facebook, TikTok, all the Rena Malik MD. My largest platform is YouTube, where I create long form content every week, and I also post my podcast there.
That's lovely. Awesome. And a question for you. How do you start your day? What's your
How do I
morning
start my
routine,
day?
morning ritual? Get
I-
you
You
off
know,
on the
I'm
right
not
foot.
I'm not one for morning rituals. I really am not. I usually walk my son to school on the days I work from home. So that's sort of part of my morning routine is I have that dedicated time. So I get outside, I get in the sun, I walk him to school. But on days that I go in to see patients, I don't have a morning routine.
It's just out of bed, out of the
Yep.
house. Yep.
Yep.
I remember those days too. What do you do for play?
What do I do? I love going to the gym. So it's not exactly play, but I find it playful. Like I enjoy going to the gym, challenging myself, pushing myself to lift. So that's fun. And then I just play with my kids. Like we just joke and we watch TV and we cuddle and my husband and I we laugh a lot. We tell a lot of jokes. And so it's just the little things.
It is. It is the little things that make a big difference. So I thank you so much for being here as a guest on the Girlfriend Doctor Show and really applaud you on your work and your candor and the impact you're having on millions worldwide. Thank you. Thanks
Thank
for
you so
being here.
much.
I really enjoyed this discussion with Dr. Rena Malik. She is so candid and so easy. You can ask her anything. So I love women like that. And they're important to have in your corner as a physician, as a friend, as someone you can lean on. So we hit on a lot of topics today: bladder health myths, pelvic health, sexual function, issues of incontinence, addressing low libido, testosterone, reigniting intimacy. And navigating medical care. How do you navigate that visit? Being clear to ask for what you need, and really insist that your issues be addressed because there's always one next right step. There's always something we can do. And when it comes to, using hormonal therapy, asking questions, being open, interviewing providers too. And she mentioned a couple times pelvic floor physical therapist. I highly recommend that. And if you're having any issues in sexual health, my 5-week course called Sexual CPR, fun name, very holistic program. We go into these issues, the 7 main areas that can affect our intimacy and desire and libido, our sex drive, including issues with physical issues, the pelvic floor, hormonal issues, medical issues, what medications are over the counter, um, drugs or supplements can be affecting your ability to orgasm. It's often eye opening, as well as understanding your erogenous zones, having the words and ability to express what you want intimately and address those issues from a very educated and holistic place. So that is my program, Sexual CPR. You can find out information about it at sexualcpr.com. Thank you for being here today, and I love being your girlfriend doctor. Till next time.
Thanks for watching another episode of the Girlfriend Doctor podcast. Check out all the links below for more.